let's pick up where we left off. If you recall, we were covering still acidosis, metabolic acidosis, and we were reviewing the high anion gap metabolic acidoses. I won't go through this in detail, but let's go back to the end of our last conversation. I might come back to this to reference it. Here we were discussing salicylate toxicity as a cause of high anion gap metabolic acidosis. Notice that salicylate toxicity falls within the ketoacidosis variant of high anion gap metabolic acidosis, as well as the lactic acidosis. This is, whoops, I am seeing, it's under mitochondrial dysfunction. Salicylate toxicity is a mitochondrial disorder, and so that's a cause of lactic acidosis. So highlighting once again, even though we sometimes oversimplify and think of salicylate on our list of high anion gap metabolic acidosis from salicylic acid, it's actually the accumulation of lactate and keto acid that causes the high anion gap metabolic acidosis. So we started this conversation. I'm going to review where we've traversed so far, and then we'll end up the conversation on this phase 3. So remember, when we started our conversation around salicylate toxicity, it progressed through various phases, one of which is, as you recall, is from medical student years. It causes a respiratory alkalosis, hyperventilation. There's a direct stimulus of the ventilatory centers of the brain, causing again, respiratory alkalosis. Often you'll get a drop in serum bicarbonate in compensation to a primary respiratory acidosis. So already the needle is moving. The bicarb is falling. We talked about how that loss of an anion in the urine, in this case bicarbonate, obligates the loss of cations in the urine. So setting up the perfect storm that follows, okay, where I'm progressively K depleted. That becomes relevant to the pathogenesis and the management of this disease, right? We see symptomatology in the early phase. We've gone over that already. Tinnitus is a classic one. You'll come from medical student study. Okay, so here's where I start to develop the clinical consequence, of this K wasting. I have this paradoxical aciduria, right? What is this paradoxical aciduria? Well, even though I am, as a result, I'll put it this way, as a result of the K deficit, I began to make an even more acid urine, right? So the normal response actually to a primary respiratory alkalosis is to have an alkaline urine, right? I'm dumping bicarbonate. That's how I compensate for alkalosis, right? But I start to actually dump an excess of acid during the later phases of this clinical scenario. And that is in response to the K deficit. So we've gone over the collecting duct physiology. Let me highlight that once again by going back to our tubular transport map. So we're in the collecting duct. You'll recall that there is an HK exchanger, right? And that transporter in the apical membrane of a alpha intercalated cell, I know that's a lot of words. Let's get the picture here. In response to the need for K conservation, again, here we are in the collecting duct, right? You have your principal cell, which is tasked with reabsorbing sodium, water, and secreting K. You have your alpha and beta intercalated cells, which are primarily tasked with handling acid loads, alpha for acid, beta for base loads. And we're here focused on the HK ATPase counter transporter, right? So if I get progressively K depleted, I get an upregulation of HK ATPase activity. In response to K depletion, there is an emphasis on K reclamation at the expense of further proton secretion. Okay, so that becomes consequential in maintaining a metabolic alkalosis, which we'll talk about, but I'm going to anticipate that conversation now. One of the main maintenance factors of alkalosis is K depletion. Okay, let's walk through that. If I am K depleted, I conserve K in part through HK-ATPase activity at the expense of more proton secretion. That's bad if I'm alkalotic, right? Ideally, I dump base, not more acid if I'm alkalotic. So this would be a maintenance factor for metabolic alkalosis. That is K depletion. Here you can see it with relevance to salicylate toxicity. Let's segue to that now. If I am secreting protons in the urine, then I am more likely to have salicylate exist in the lumen, not as its conjugate base, right? Salicylic acid can dissociate into a proton and its conjugate base, right? So if there is an increase in proton secretion, then I'm driving this reaction to the undissociated form of salicylic acid. Okay, that's bad because now that it is not charged, it can more easily be reabsorbed or traverse this epithelium. It is no longer trapped as a charged species in the tubular lumen. One of the main management principles of salicylate toxicity is I want to enhance renal clearance of salicylate. You do that by maintaining salicylate as its conjugate base, okay? Hence the need to have an alkaline urine, ideally, right? So this is bad, right? Proton secretion is bad if I'm trying to enhance salicylate clearance, okay? So that's why, why we must emphasize the importance of repairing the K deficit. Repairing the K deficit enhances salicylate clearance. Why? Because it avoids the more acidic urine in which salicylate exists as its uncharged state, right? Salicylic acid. All right. So again, we've gone through some of this phase 2 paradoxical aciduria, even though the normal response should be to continue to dump base in the urine in compensation for the primary respiratory alkalosis, you start to exhibit an aciduria, okay? All right, now we're getting into phase 3. I'm overtly K depleted in many cases. So I'm overtly K depleted in many cases. This is when I start to accumulate that elevation in anion gap. And then recall again, I've already made this claim. I'm just getting to reinforce it now, that this causes primarily an elevation in anion gap through the accumulation of lactate and ketoacids, right? We talked about how that occurs in a previous discussion. The thrust is it's a mitochondrial toxin. Okay, so that's the punchline. All right. Now, in this case, you can have more overt signs of toxicity. They can get hyperthermic, even though that seems counterintuitive when you're giving aspirin. There's a problem with, temperature regulation that can occur. And then you can get overt CNS toxicities. Okay, treatment. Let's move to treatment. Obviously, we're interested in how much salicylate is in the body. We're measuring salicylate levels. They take time to come back. We're also making treatment decisions based on the severity of clinical manifestations. Another important factor is if there is reversible kidney dysfunction. Again, the principle is let's get rid of salicylate primarily through renal clearance if possible. If they're just volume depleted, renal clearance increases simply by volume resuscitation. That's fantastic. Salicylate clearance would presumably increase as GFR increases. But if you have ATN, you have a roadblock in trying to clear salicylate. And so you would have a lower threshold for instituting renal replacement therapy. Okay, so that is one operating principle. We're really focused on here, alkalinization of the urine, okay, as well as the systemic pH. We'll talk about that in a little bit more detail. Correcting K deficits, another operating principle, and then making a decision around renal replacement therapy. Those are sort of the pillars of your contribution to the case. There is another facet to understand, even though that's typically not going to be your treatment decision. You can actually have impaired transport of glucose into the CNS that can occur through some of the downstream effects of salicylate on other epithelial functions. In this case, the epithelial that lines the CSF. So if an individual has altered consciousness, even if their glucose is normal, one of the management principles is give them glucose anyway. Again, that's typically not going to be your treatment decision, but that is a phenomenon to be aware of. Okay, so let's go through some of these things, these pillars. Again, alkalinization, why is that important? Well, we talked about that's helpful to have to try and limit the aciduria, right? You're trying to get more base into the urine. So why do we try to do that? Once again, we do that because we're trying to trap salicylate as its conjugate base. That is the salicylate anion, right? That enhances renal clearance. Okay. The other thing is that when you similarly trap salicylate in the non-CNS compartment. Okay, you're trying to limit salicylate getting into cells, right? Getting into cells where it can cause that mitochondrial dysfunction, right? So if I can trap salicylate as its conjugate base in the ECF, then that would be potentially helpful to minimizing toxicity. It would then also help me to limit the penetration. This is my little brain here, cerebellum here. So the entrance of of salicylic acid into the brain or in the CNS. These are operating principles that are elementary in the approach to salicylate toxicity. So even though patients have often a primary respiratory alkalosis and therefore already have a pH that may be 7.5, this is a scenario in which you still sort of, let's call it ride the lightning. You give base to a patient who has a pH of 7.5. You start worrying about the denaturing of proteins, especially in an alkaline environment as opposed to acid environment. But still, this would be a scenario where you, again, ride the lightning, okay? We want to, volume resuscitate if they're volume depleted. Remember, they have that salt wasting phase that's obligated, right? As they're losing bicarbonate in the urine or keto acids and lactate in the urine, those pull, salt into the urinary space as well, causing progressive volume depletion. The nausea and vomiting contributes to that as well. We've gone over the need for aggressive K supplementation. Even if they're normal kalemic, probably should give them K, okay? Assume that they have a K deficit. Try to enhance the acid excretion rate. The base excretion rate by closing a potassium gap, okay? Give some glucose, and then sometimes you're needing to do renal replacement therapy, right? There's some sort of salicylate levels that factor into that clinical decision. Some would say, again, 80 milligrams per deciliter, but certainly a lot of the symptomatology drives this decision, right? If you're very sick, you're going to have a lower threshold for RRT, right? Advanced renal failure would impair, whether it's acute or chronic, will impair the clearance of salicylate. And so that would make you lean towards earlier initiation of renal replacement therapy. Often this is a decision that's made in concert with toxicology. I sometimes share that my neighbor is the toxicology fellowship director. And one of our first interactions, even before he moved to the, well, right about the time he moved to the neighborhood, was he was on, I was on. He really felt strongly a patient needed to be dialyzed. I did not. And we didn't. The patient did well. As a joke, I left him a bottle of aspirin at his doorstep when he moved to the neighborhood. I said a note that said, "Don't worry, you'll pee it out." Okay, he's a good guy. All right, so let's move on to toluene ingestion. So this would typically be considered a non-GAP metabolic acidosis, okay? It goes over a principle which we've already talked about, which is worth repeating. That is, even if you have a strong acid, in this case, I'll keep hippurate, right? Toluene results in the creation of hippurate, right? Toluene is metabolized eventually into hippuric acid. Hippurate is a strong acid, meaning at a pH of 7.4, it's going to dissociate into a free proton and a conjugate base. Okay, so one would presume then that if I have hippurate that's circulating, then, and it's negatively charged, I would have a broadening of my anion gap. And that is true if I have impaired renal function, right? If I cannot excrete hippurate into the urine, then because of a problem with acute or chronic renal insufficiency, this is what is happening, right? The proton is liberated. The proton binds with bicarbonate to form CO2 and water. And so the net result is a drop in HCO3, that is metabolic acidosis, and an elevation in my anion gap. That's the mark, right? Accumulation of hippurate, drop in bicarbonate, high anion gap metabolic acidosis, okay? However, if you have avid excretion of hippurate, okay, then what ultimately happens, let's take the X off, right? What ultimately happens is, yes, I generated hippuric acid. Yes, it dissociated into a proton. Yes, it consumed bicarbonate. So I have metabolic acidosis. But I have excretion of the conjugate base into my urine. My anion gap is no longer broadened. This happens with keto acids. So every patient who develops ketoacidosis actually initially has a non-GAP metabolic acidosis. When they develop pre-renal renal insufficiency or really rapid ketoacidosis or ketoacid generation, and they accumulate that conjugate base, that's when the anion gap starts to broaden out, okay? Hippurate is a special molecule. You may recall from reading old papers, well, we do inulin clearance to measure GFR. We do para-aminohippurate clearance to measure renal plasma flow. What's unique about hippurate is it is so avidly taken up in the paratubular capillaries that if you measure basically a venous hippurate level, it goes to 0, right? Every milliliter per minute of blood that is delivered to the kidney is cleared of hippurate. That's why it's a marker of renal plasma flow. Inulin doesn't have that property. Only a proportion of the inulin that's delivered to the kidney is cleared through glomerular filtration. Hippurate is cleared in large part through tubular secretion very avidly. Okay, there's some glomerular filtration, but also very avid proximal tubular secretion of hippurate. And so it is a very rapidly cleared molecule in reasonable renal function in the context of reasonable renal function. So most of the time it causes a non-GAP metabolic acidosis. I've given you the exception here, toluene ingestion with renal dysfunction. Okay, let's move on. Let's talk about, we're almost done. We're going to the non-anion gap metabolic acidosis. A lot of brain twisting over there. Okay, so let's finish off this last high anion gap metabolic acidosis, pyroglutamic acidosis or 5-oxyprolenemia. It's not that rare, even though it seems like it's an uncommon one. Why? That's because it often is the result of a perfect storm that's quite common. You have a patient who has malnourished state. Often it's a patient with, let's say, cancer, who's on narcotics that contain acetaminophen in combination with hydrocodone, for instance. It's part of the chronic pain management of a cancer patient with uncontrolled disease. So that's a classic context in which this occurs. And so a patient who is malnourished actually has a low glutathione store. Glutathione is actually a regulator of a enzyme that metabolizes glutamate to this gamma-glutamylcysteine molecule, okay? This happens to be metabolized to pyroglutamate or 5-oxyproline. Those are synonyms, okay? This is a strong acid, and the production of 5-oxyproline is often faster than its metabolism back to glutamate, okay? So when I have glutathione deficiency, I have an upstream acceleration, let's say, of this enzyme dumping more substrate into this pathway, and the exit out of this pathway is relatively slow. Okay, so I get an upregulation of more proximal metabolism, and this exit strategy is relatively slow. I get an accumulation of a strong acid, pyroglutamate or 5-oxyproline. Okay, you can measure, or you can, how does this present? It's often in the state of multi-organ dysfunction because, there's a lot of other things that are often going on with these patients. There may be a direct toxicity from the 5-oxyproline in causing some of the organ dysfunction. But I would say I see some of these diagnoses actually in the ICU more commonly than on the floor, where you have an anion gap metabolic acidosis that is disproportionate to the elevation in lactate. You go after this, you measure this by a urine anion screen or a urine organic acid screen. That's the orderable. And you'll detect pyroglutamate in the urine, or the synonym 5-oxyproline in the urine. Okay, so how do we treat this? Obviously, we stop the acetaminophen, which I guess I didn't even emphasize that aspect of this. The acetaminophen also depletes glutathione. I failed to sort of mention the obvious. So it's a glutathione deficiency that is the result of, malnutrition, as well as acetaminophen metabolism, which also utilizes glutathione in the metabolism of acetaminophen. Okay. All right, so we treat with stopping this acetaminophen. We try to replenish glutathione through a precursor of giving acetylcysteine. Okay. All right, advanced renal insufficiency is a classic, another context in which we get an accumulation of acids that broaden the anion gap. In this case, this is primarily sulfates and phosphates. Uric acid as well can accumulate. But these are the metabolites that are accumulating in advanced renal insufficiency. Moderate renal insufficiency is a non-gap metabolic acidosis, but as you get more severe renal insufficiency, you accumulate sulfates and phosphates, which cause a broadening of the anion gap. Okay. Any questions before we move on to non-anion gap metabolic acidosis? I don't know that we have to come back to here just to highlight some of the differential of anion gap metabolic acidosis. You'll see some of these that we've already talked about, toluene with renal insufficiency. Another one we didn't talk about, but that actually is clinically relevant because you guys prescribe this, sodium thiosulfate causes a high anion gap metabolic acidosis. It's actually not known what is the conjugate base or the strong acid that is circulating, it probably is hydrogen sulfide, which dissociates, but we don't actually know, even though this is a common phenomenon. When you give sodium thiosulfate for calciphylaxis, a known side effect is a acidosis, which is typically high N-gap and is often dose limiting. Okay, let's move on to the non-N-gap metabolic acidosis, okay? So we can broaden, or we can approach this through sort of an overview. There's often either renal or non-renal bicarbonate loss. That's one way you can get a non-gap metabolic acidosis. I can have a problem with renal acid excretion. I can dilute my bicarbonate. I can gain an acid with chloride as the conjugate base. That's essentially hydrochloric acid. But there's other, maybe less intuitive forms. Lysine chloride is actually available for prescription. Arginine chloride is available for prescription. That's an amino acid. I think we talked about this when we created the fund of knowledge to approach this topic, right? I'll scroll back to that, right? We said the metabolism of amino acids or protein is your acid load. And interestingly, it is the quote unquote basic amino acids, lysine and arginine, which carry a proton, which are acid loads. Why? Because, again, in order to do something useful with arginine, which is naturally at a pH of 7.4, holding on to a proton to that extra amino group, I have to liberate that proton in order to do something useful with arginine, right? In order to strip off some of the ammonia groups to make urea, which is uncharged, one of the first things I need to do is to strip off the proton. So again, consuming arginine chloride is actually akin to giving hydrochloric acid. Okay, it increases the it causes metabolic acidosis without an accumulation of a charged conjugate base. So you get a non-gap metabolic acidosis from arginine chloride. You can, in an experimental setting, give ammonium chloride. That is also akin to giving hydrochloric acid. Okay, ammonium chloride dissociates, that ammonium dissociates into ammonia, uncharged. The proton had to consume a base, a bicarbonate. I get the chloride as this obligate anion that you must administer with ammonium chloride, right? So even though I've sort of said, maybe it's most intuitive to understand hydrogen chloride causes a non-gap metabolic acidosis, there are other variants of hydrogen chloride or hydrochloric acid loading. Arginine chloride, lysine chloride, ammonium chloride are other examples that can cause non-gap metabolic acidosis. Gain of acid with chloride as the conjugate base. Okay. I can also gain acid, we've already talked about this, with elimination of the conjugate base into the urine, right? Those early ketoacidosis originally manifest as a non-gap metabolic acidosis, okay? All right, so here's the differential. We won't go through this, we'll go through the concepts and then we'll come back to this, okay? You can see, for instance, I've highlighted things like lysine chloride. Here's some other clinically relevant ones. You might not see many people get lysine chloride or arginine chloride, even though this is used as a secretagogue to assess endocrine function. So sometimes you might see it. These you will see as a practicing nephrologist, right? Sevelamer carbonate is the more common variant of sevelamer, or Renagel, or Renvela is the trade name, or the trade name, is not going to cause this. But the first generation, which is still clinically available for prescription form of sevelamer, was sevelamer chloride. So it causes a non-gap metabolic acidosis. What happens in the gut is functionally akin to gaining hydrochloric acid. Okay, let's see what happens. You have transporters in the gut which are countertransports for chloride and bicarbonate. Okay, so when I have sevelamer chloride, it is a binding resin. That binding resin has essentially, again, let's say, positive attributes. The chloride is the obligate anion. This is what binds that negatively charged phosphate, right? The sevelamer binds the phosphate, right? But it liberates a chloride, right? That chloride becomes absorbed, okay? And I often lose bicarbonate into the gut lumen as I reabsorb that chloride load. Okay, so the net result, loss of bicarbonate, is the same as gain of proton, right? So the net result is a non-gap metabolic acidosis. You see the same thing with cholestyramine. I've seen this several times, okay? That is being administered for chronic diarrhea. Sometimes we use cholestyramine to manage chronic diarrhea. Sometimes it's used for managing binding C. diff toxin, okay? You also use it in rare cases for management of dyslipidemia. The main one that you use for dyslipidemia is cholestyramine. You'll also use this for pruritus in a patient with chronic liver disease, right? So you see some patients who are on chronic cholestyramine or cholestyramine, even though, it's not that common, you do see it. This is another binding resin, right? In this case, it's designed to bind bile acids, negatively charged bile acids. These drugs are basically chloride containing binding resins, okay? That can do the same thing, bind essentially, or liberate a chloride as they bind in this case, a bile acid. And then that chloride absorption is coupled with bicarb loss through chloride bicarbonate exchange in the gut lumen. The net result is a non-gap metabolic acidosis. All right, so let's go through some of these. Again, I've divided the non-gap acidosis into bicarbonate loss, extrarenal, reduced renal excretion, and that's when we're going to talk about the RTAs. And then, although renal loss of bicarbonate loss is also a form of RTA, in this case, a proximal RTA. And then we can say bicarbonate dilution. I'm not going to say much about that, so I'll just say this now as an interesting thought to digest. When you give sodium chloride, it causes what we call many times understand as a dilutional acidosis. I think you certainly know that or aware of that. But what you may not be aware of is that if you give enough D5W, actually, you can get a dilutional acidosis as well. And there's a whole, the maybe intuitive way to understand it is you give fluids without bicarbonate, you dilute the serum bicarbonate, right? But there's another approach to that question or phenomenon that gets you into a rabbit hole called Stewart acid base, and things like strong anion gap, or strong ion difference, I should say. So, it may be a rabbit hole you're interested in traversing at some point in time. Okay, let's keep it simple, dilutional acidosis. All right, so gain of acid, where the conjugate base is a chloride, we've already gone over. Gain of acid, where I excrete the conjugate base, are everything that we've talked about, right? The moderate ketoacidosis with intact renal function, hippurate toxicity or hippuric acid toxicity, the lactic acidosis, D-lactic acidosis. And actually, if I essentially are taking in basically large amounts of cysteine or methionine, that is essentially, let's map that out. We actually use that sometimes in managing certain patients with kidney stones. So one way to acidify the urine, right? If I have a calcium phosphate stone former, let's make this clinically relevant so you don't zone out and say, who cares about sulfate as as a cause of a high, or cysteine or methionine consumption as a cause of metabolic acidosis. One way that we manage calcium phosphate stone formers, we'll talk about the fact that the main pathophysiologic factor in these stone formers is the urine pH is too alkaline, okay? The pH is much greater than 6, right? That makes calcium phosphate less soluble. One way that you can manage some of these patients is to give them methionine. Methionine essentially is metabolized to, it's one of your sulfur-containing amino acids. Cysteine is another one. But when I metabolize methionine, I'm essentially getting sulfuric acid, okay? So this is going to be 3+, or if I remember correctly, the valence of sulfate is 3-. Okay, so what happens is this is a conjugate base that is avidly excreted by the kidney in the urine. I liberate the 3 protons. I consume bicarbonate with that. The net result is a metabolic acidosis. Okay, so that is another form of gain of acid when my conjugate base is excreted. In this case, it's sulfate ion. Okay, let's go through some of these then. Loss of bicarbonate, extrarenal bicarbonate losses. Let's go through what is the electrolyte content of a variety of enteric fluids. Okay, so you'll know what would be the metabolic consequence. Obviously, we know that there's very little bicarbonate in gastric, right? Gastric fluids. That's typically a very acidic fluid, and so there's very little bicarbonate in that. The loss of gastric fluids is a loss of acid. Loss of acid is a gain of base. So that's going to be a topic we discuss when we're talking about metabolic alkalosis, right? NG suction will be one of the things we cover as a cause of metabolic alkalosis. But notice that there are other fluids, if you lose enough of it, absolutely can cause metabolic acidosis, right? Pancreatic fluid losses would be one that can easily cause a metabolic acidosis because every liter of pancreatic juice has a really pretty high bicarbonate content, right? Higher than systemic bicarbonate concentrations, right? 50 to 100 millimoles per liter in comparison to your ECF bicarbonate of only 25 or so, okay? Similarly, bile has a lot of, bicarbonate in it, 50 millimoles per liter as opposed to the 25 millimoles in your ECF, all right? Stool has bicarbonate in it. Ileostomy outputs have bicarbonate in it. These are ways that people can lose a fair amount of, they can manifest a fair amount of extra renal bicarbonate losses. I would say this is an underappreciated cause of metabolic acidosis. I recently managed a patient in discharge clinic over at Parkland. He had moderately severe metabolic acidosis. And, we said his CKD, it was all CKD related. But he also had an ileostomy, and nobody talked to him about his ileostomy output. And he's had actually repeated admissions where his bicarbonate is in like the low double digits, like 11, 10. And all that we can come up with is give him more bicarbonate, be compliant with bicarbonate. And then just took a, history taking and say, hey, how much are you putting out in your ileostomy? Wow, that's not insignificant. You're even seeing pill fragments in your ileostomy output, which GI basically just ignored. So, okay, well, he has inflammatory bowel disease, and well, let me not dog on our GI docs too much, but his IBD drug was coming out undigested in his ileostomy output, and there was no decision around that by GI. Nephrology said, you should take some Imodium. That will help with your metabolic acidosis. My management is not give you more base, it's reduce your loss of extrarenal bicarbonate. That is the management. That is a phenotype I see a lot of, ileostomy patients who come in with repeated AKIs with severe metabolic acidosis. And much of my treatment around that is drink more soup, okay? And let's give you some anti-diarrheals. We ignore that, I think, too much. Secretory diarrhea, inflammatory diarrhea, other ways you can lose a lot of bicarbonate from the body. Again, non-renal or extra-renal bicarbonate loss that can cause, obviously, a metabolic acidosis. Okay, let's go to urinary diversion now. By the way, here's where you find some of the electrolyte contents. I show you some of this as well in our topic of discussion in the dysnatremias. This is relevant as you understand the influence of these losses on serum sodiums. Is it a hypotonic loss? Is it a hypertonic loss? Right? So we've gone over how if you lose pancreatic juices, you can get hyponatremic in some of these scenarios, because in Edelman's terms, that's a lot of cation to lose, right? A lot of sodium and potassium to lose. Okay. In general, if you're losing, diarrhea, you're most likely to see hypernatremia, right? Because they have more water loss than salt loss. Concepts we've gone over before, just to, let's say, push on that neuron, remind that neuron to keep working. Okay. All right, let's move. Urinary diversion, another form of non-GAP metabolic acidosis. The most common is an ileal conduit. Rarely we're going to see ureters that are tied into a loop of distal colon. That is your sigmoid colon, right? You can appreciate that would be, probably not the ideal scenario. You'll have watery stools, and if it's looped into, a distal piece of colon, right? But it can be done. It has been done. Most of the time, we're seeing ileal conduit patients where they have basically a surgically created bladder of sorts, or it's not a bladder. It doesn't tend to hold on to fluid, but it's just a conduit, as the name applies, from the ureter to the anostomy bag on the skin. And so they have urine that's coming out through an ileal conduit into an ostomy bag. Now, when you have dysfunction of that conduit, okay, that's when you're more likely to see this, right? You're less likely to see metabolic acidosis when you have urine that is, let's just do it this way. I need more space. Kidney, ureter, loop of bowel, okay, that has been mobilized and then is tethered to an ostomy bag on the skin and goes out of the body, right? If I have reduced or have minimal contact time between urine and this loop of bowel, I'm less likely to manifest a metabolic acidosis. However, if I have a problem with a stomal stenosis, that would be a scenario in which I can manifest this. Sometimes patients have mobilized loop of bowel, typically a loop of ileum, to create a continent urinary diversion, where actually a loop of bowel is anastomosed to the urethra, and they have actually a pouch that collects, like a bladder, urine in it. And so there's prolonged contact time with that. Now, typically those patients are told to do timed voids to minimize some of the metabolic dysfunction that results from that prolonged contact time, meaning they set an alarm and pee at night, right? That also reduces the amount of urinary reflux when you have those continent diversions. More commonly than not, though, we have the incontinent diversions where it's draining to an ostomy bag on the skin, and you'll see this when you see stomal stenosis. Okay. All right. So what am I seeing? I have a metabolic acidosis. Remember, I told you essentially ammonium chloride is if I administer ammonium chloride to you, you manifest a non-GAP metabolic acidosis. In essence, that's what's happening when you have this urinary diversion with prolonged contact time. Your kidney is trying to get rid of acid in the form of ammonium chloride. Ammonium we talked about when we talked about net acid excretion. Ammonium is your modifiable base that accepts protons in order to enhance acid excretion. So when you need to excrete more acid, you make more ammonium. You excrete it as ammonium chloride. You don't just keep driving your urinary pH from 5 down to 4, down to 3. You excrete more acid by dumping more of acid in the form of ammonium, right? Protons bound to a urinary buffer. Okay, but when I have this prolonged contact time, essentially what happens is I reabsorb ammonium. It's interesting. Ammonium has a charge of 1 plus and let's call it a radial dimension that approximates potassium. And so even along the length of the nephron, you can see that whenever I'm able to reabsorb potassium by a transporter, for instance, the loop diuretic sensitive sodium potassium 2 chloride transporter, whenever it can transport a potassium cation, it can also transport a ammonium molecule, okay, because it has relatively similar molecular dimensions. Okay, and so anytime loops of bowel have potassium reabsorption transporters, and so that ammonium that your kidney is trying to excrete in order to excrete acid becomes reabsorbed. So I'm reabsorbing the ammonium that is purposed for acid excretion. And so I have inefficacious acid excretion. The chloride also participates in that, similar through that chloride bicarbonate exchanger, right? When I reabsorb chloride, it is often in a counter transport mechanism with bicarbonate. So I'm losing bicarbonate into the urinary space. Often patients with urinary diversion, if you check their urine pH, it is typically always in the 7s or 8s, okay? And that's because they have this chloride bicarbonate exchange that's happening, okay? So the net result is a non-GAP metabolic acidosis, right? The ammonium is metabolized as it's reabsorbed. It's metabolized into urea, as well as which is uncharged. In order to get to an NH4 plus to a urea, I had to strip off the proton. That proton consumes bicarbonate, and that we've already spelled that out multiple times. So you get the clinical picture that is seen. Bicarbonate drops, anion gap is not broadened, and this is something to recognize. All right. Questions about urinary diversion as a cause of non-GAP metabolic acidosis. Remember again, prolonged contact time, sometimes through continent urinary diversion where a neobladder is created, sometimes through ostomy stenosis or stomal stenosis. Those are contexts in which you might see this, okay? Now, when you have urinary diversion into the sigmoid, there's also a factor at play in which urea may be metabolized to ammonium and bicarbonate through the activity of urease. Okay, so not only do you have, again, impaired ammonium excretion, but essentially you are making more ammonium by cleaving urea into ammonium and bicarbonate. So there's another sort of acid load that may result by metabolizing urea into ammonium and bicarbonate. The bicarbonate goes out into the urine, and then the ammonium is reabsorbed and causes a non-GAP metabolic acidosis. Questions? Okay, we're pretty much at the end of our hour. Let me see if I can just build a concept and then develop it next week. We're on to the renal bicarbonate losses here, or let me see if I have to come back to extrarenal bicarbonate losses. Maybe one other one I will mention is in research settings, we can give calcium chloride. Research settings, if you want to precipitate a non-GAP metabolic acidosis, you can give ammonium chloride or calcium chloride. Calcium chloride works through maybe a familiar mechanism now. Remember again, I have bicarbonate exchange with chloride, right? And when I give calcium chloride, the chloride is absorbed, calcium is lost in the lumen, and also is trapped through binding with calcium. That forms the less soluble calcium carbonate. And so that goes out in the stool, okay? So calcium chloride is another cause of a non-GAP metabolic acidosis and is used in certain research settings. Here we are now going to traverse the differential of renal bicarbonate loss. Notice that we're going to talk about proximal RTAs, the use of carbonic anhydrase inhibitors that are obvious and then less obvious. Topiramate and zonisamide have carbonic anhydrase activity. Type 3 RTA is a defect in carbonic anhydrase. You can say that when you give carbonic anhydrase inhibitors, you're causing a type 3 RTA. Why is that? What is type 3 RTA? It's when you have both the combined and distal RTA essentially. And we've seen we've seen this in a Sjogren's patient. But the point I want to make is that even though the cartoon version of carbonic anhydrase inhibitors is that it is a proximal diuretic, that is not true. You have carbonic anhydrase throughout the nephron. I'll highlight its presence in, for instance, the alpha intercalated cell intracellular environment, in the apical membrane, in the basolateral membrane. And anytime you're trying to secrete protons, it's always going to be in a cell that essentially expresses carbonic anhydrase. So when you inhibit carbonic anhydrase, it affects sodium and proton transport throughout the nephron. This is actually a form of type 3 RTA. If I have a mutation in carbonic anhydrase type 2, I have both proximal defect in urine acidification as well as distal defect. All right, so those will be concepts I develop a little further in next week's conversation. Questions?